Okay, so good evening, everybody, and welcome to tonight's webinar, Mandatory Reporting for Child Sexual Abuse. We are joined tonight by speakers Dr. May Sue, Stacey Ullman, and Rachel Neal. My name is Jovi, and I'm the Education Events Officer for the Specific Interests at the RACGP. Now, before we continue, I'd like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea in which we live and work, and we pay respects to elders, past and present. I'd also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. Myself, I'm joining in from Guringai country, located on Sydney's North Shore. We seek to honour the lived and living expertise of all victims and survivors of child sexual abuse, harnessing all ages, cultures, abilities and backgrounds, and commit to substantially addressing the harm of child sexual abuse now and well into the future. We recognise that there are children and young people today who are experiencing sexual abuse and dedicate ourselves to doing all we can to expedite and promote their effective protection and care. We recognise that some participants listening to this webinar may have their own experiences that may impact how they engage with what we discuss today.
I'd also like to acknowledge that for those of you who are attending via Victoria, that we acknowledge the difficult circumstances which are occurring with the current investigation of alleged sexual abuse in childcare centres across Melbourne. The RACGP Victorian faculty and the Department of Health are going to be running a joint webinar tomorrow evening, and we'll have details about that webinar at the end of this webinar as well. And in that webinar, they will be discussing specific details about what GPs do need to know, locations affected and required testing, and the role of what supports exist in regards to supporting GPs and families who are affected by this situation as well. I recognise that for some who are listening in to what we talk about tonight, it will be challenging. And so here are some support services which you may already be aware of that may also be relevant for you.
Perfect, thanks, May. So I'd like to now take the opportunity to thank our partner, the National Centre. The National Centre for Action on Child Sexual Abuse is a symbol of hope and an essential vehicle for action for many victims and survivors of child sexual abuse. Founded in late 2021, the National Centre is a partnership between three respected organisations with strong histories of leadership in responding to the child sexual abuse, the Australian Childhood Foundation, Blue Knot Foundation and the Healing Foundation. The establishment of a national centre to raise awareness and understanding of child sexual abuse, support help seeking and guide best practice was a key recommendation of the 2017 Royal Commission into Institutional Responses to Child Sexual Abuse. So I'd like to now hand over to May to start the session.
Great, thank you. So those of you who are in the webinar might already know me. I'm an academic GP with specific interests in mental health, complexity, abuse and violence and neurodiversity. I still continue to work part-time alongside academic roles. I'm also the chair of the RACGP Specific Interest Group in Abuse and Violence in Families, and I'm currently a PhD candidate at the Translational Health Research Institute at Western Sydney University on the topic of abuse and violence. So I'd like to introduce our panellists for tonight. We're really delighted to have with us Stacey Ullman, who's an accredited social worker with over 16 years of experience in child protection, family and sexual violence practice and training. She's a manager of practice development and training at the National Centre for Action Against Child Sexual Abuse and has been the project lead for Strengthening Primary Healthcare Responses project, which commenced in 2023. We're also joined by Rachel Neal, who's the Executive Director, Integrated Practice of Knowmore Legal Service, which is based in the Brisbane office. Rachel's worked at Knowmore since November 2019, and she's worked in the community legal sector for many years in various roles. She spent her legal career committed to helping vulnerable people to access their rights within a strong framework of trauma-informed and multidisciplinary care. So what we're hoping by tonight is that we will be discussing the prevalence of child sexual abuse within Australia and also some resources which they're going to share with us tonight about how we can strengthen our responses identification and response for child sexual abuse. Rachel's also going to be speaking to us about the legal obligations and requirements for mandatory reporting, and we do recognise that this is a topic that general practitioners often feel uncomfortable about. Hopefully we'll make it clearer about how to go through that process, including those sort of grey areas and uncertain areas, which I think GPs often do find really challenging to work with. And also outline the benefits of primary health networks, family, domestic and sexual violence recovery pilot sites for general practice. So I really hope for tonight that it will be about how that we can all be working together as teams to be working on this issue. So we're going to be starting with a poll. You'll see the poll come up and you won't see. You'll see the polls come up and I'll let you know the responses of that soon. So we'll just give you a minute just to respond to the poll. Well, we've actually just had a comment about what's happened recently in the news related to the topic. We do recognise that it's obviously a topic of interest. That will be specifically discussed in the webinar tomorrow. What we are going to be discussing during this webinar will be mandatory reporting for child sexual abuse. I didn't discuss it in the learning objectives, but what we are hoping is that questions which arise in the question and answer, I'll be responding to. But for those which we're not responding to tonight, we're going to collate those so that we can also gather them for our second webinar, which will be occurring in September as well. And we will have a very short period of time at the end if there are some relevant questions which might be better for us to discuss in person. So I gather by the poll responses that most of the people who've actually come here tonight probably are a little bit uncertain about how confident that they feel on recognising child sexual abuse. In fact, probably a third of people really felt neutral about the issue, with about a quarter of people feeling not confident at all. It's good to hear that maybe a reasonable proportion of people also did feel confident about being able to recognise child sexual abuse. Thank you. So we've got a second. If you can also respond to this poll. So just as a reminder, the first poll question was on recognition of child sexual abuse, and this poll is on responding. So in terms of responding to child sexual abuse, it was probably similar sort of numbers where more people felt not confident or somewhat confident as opposed to confident. 11% of people felt confident compared to probably a third of people who felt not confident at all. Thank you. So I'm going to hand over to Stacey. Thank you.
Thank you, May. I'd like to start by acknowledging that I'm joining from the lands of the Gubbi Gubbi people today, and also want to extend the acknowledgement to those with lived and living experience who are joining us today, also across Australia, and express really sincere gratitude for the expertise and guidance in the development of resources through the National Centre that we'll reference through the presentation tonight. For the National Centre, as Jovi mentioned, we commenced in 2021 as a partnership across those three organisations. We have a singular focus on child sexual abuse, and that's across the lifespan. So we're looking from childhood right across to older age and to adults. And we're really determined to see child sexual abuse stop, and that's across all of our communities, homes and institutions. So you can see on the screen there, we have a number of different functions for the National Centre. We support and promote strategic research. We address knowledge gaps. We're looking at building a workforce capability, which is part of why we're presenting in partnership with the RACGP tonight, reducing stigma and undertaking awareness-raising activities, and leading collaborating for systemic change. And you can see there we've got some statistics on the side, and we're going to talk about those in a little bit more detail coming up in one of the other slides. We've got 1 in 3 girls and 1 in 6 boys in Australia who've experienced child sexual abuse. Go to the next slide, please, Jovi. Thank you. So for those who are unaware, the National Centre commenced a 3-year project in 2023, which is funded by the Department of Health, Aged Care and Disability. So we have a number of different resources that were developed as part of that project, and it's really around how we can build and strengthen the capability of primary healthcare practitioners, including general practitioners, to support those who have experienced child sexual abuse or sexual violence as children or adults. So we have a range of different resources that have been developed across that. We have things such as a video that was designed specifically for general practitioners. We have practice considerations for general practitioners. And we also have a range of different practice prompts that also have an application to practice specifically for general practitioners. So we'll share some of those in the links throughout the presentation tonight. We'll also share on some of the additional resources that we talk through, particularly creating safer spaces, that will be sent out after the webinar today. We go to the next slide, please, Jovi. Thank you. So did we just want to start this by saying that the way that each victim and survivor describes their abuse will absolutely be unique, and it will be dependent on their own lived and living experience. There are a range of different ways that child sexual abuse is defined. You'll hear a few tonight between Rachel and myself when we're talking about it. And two of the most common ways that it's described is, for child sexual abuse is put simply around a child sexual abuse is when people involve children of any type of sexual activity. And when we refer to historical child sexual abuse, we're talking around abuse that occurred to someone who is now an adult when they were under the age of 18. Really want to focus on that child sexual abuse is never the child's fault. We know that children inherently have less choice and less control, and that includes over their surroundings and their interactions with adults. And there's also some power obstructions and dynamics that exist within society and relationships that contribute to and enable sexual abuse to occur. So we know from the statistics, you can see one on the screen there, from the Australian Childhood Maltreatment Study, 28.5% of the Australian population between 16 years and above has experienced child sexual abuse. So if you are a GP seeing 30 children in a day or on a regular basis, and we look at that within an equal gender split, say 15 boys and 15 girls, then on average, what we're looking at seeing is 6 girls and 3 boys out of that 30 who are currently being or who have previously been sexually abused. So we know that general practitioners are having extensive contact with victims and survivors across the lifespan. We also know that for children who experience child sexual abuse, it rarely happens only once. So there are a multitude of different times that it can occur. And for 11% of children who experience child sexual abuse, it happened more than 50 times. Over time, we have seen the prevalence of child sexual abuse by parents and parent-like figures in the home substantially decline. And you can see some of those statistics on the right there. Whilst we can see that that has declined, what we have seen is there's been a significant increase in child sexual abuse by other adolescents, and especially those who are in a romantic relationship. So you can see there we've got 12.9% in the statistics as known and 1.4% as unknown adolescents. So we have a really big need for improved and earlier prevention. Next slide, please, Jovi. Thank you. So we'll hear from Rachel from Knowmore shortly around the legal requirements surrounding mandatory reporting for child sexual abuse. And we really wanted to take this time to talk around the importance of what happens around that. So that's before, during, and also after. So many of you will be familiar with the tool 1.1, which is 8 steps to intervention, or the 8 R's, which is in chapter 1 of the RACGP White Book. We've adapted those to the 4 that you can see on the screen. So we've got recognise, respond, refer, and reflect. In the resources across the project that we'll share with you throughout tonight and after the webinar, we outline a range of different ways in which disclosure can occur and why it's important to create environments and relationships and opportunities that are really supportive of disclosure. The impacts of child sexual abuse are lifelong for victims and survivors and also their families. And there's many different biases and myths and misunderstandings that we ourselves can hold, some of which are prevalent and held up within society across Australia. One of the things we also know is that disclosure is a process and it's rarely a one-off event. And talking about child sexual abuse can be something that happens in the context of someone's broader life experiences or relationships or even their environments. And we also know from the Royal Commission that on average it takes 23.9 years to tell someone about the abuse. And for men, it took even longer. So if someone's disclosing to you as a general practitioner, or even within your friend or family network, it might be the first time they've told anyone for quite a long period of time. And we also know that the importance of responding in a trauma-informed way. So we need to reflect on how that person might have experienced us. How did we show up in terms of our body language? What might they have taken from that? How may that person have experienced the tone of our voice, or if we even acknowledged or validated their disclosure? So we need to believe someone when they disclose to us, and how each and every one of us responds can really shape the way that children and adults navigate services right into the future, from childhood through to adulthood. And Rachel will focus a lot on the legislative requirements for mandatory reporting tonight, but we also want to take a moment to really highlight that there are a range of different respective professional codes of conduct and ethical standards. And we know that the RACGP White Book has significant guidance in that space, and also for people to be aware of the child safe standards for their jurisdiction. So really just wanted to summarize and say that child sexual abuse has extensive long-term impacts across a whole range of different areas within people's lives, and everyone has the opportunity and ability to make a difference and contribute to safer spaces for everyone within primary health care. So thank you, and I will hand over to Rachel.
Thank you, Stacey. I'd like to acknowledge that I'm coming from the lands of the Ngunnawal people, and I'd like to pay my respects to elders past and present. From the introduction, you would have heard that I work at Knowmore Legal Service. Knowmore is a national community legal service. We give free advice and ongoing assistance to survivors of child sexual abuse, and we talk to them about their justice-making options, particularly monetary payments and other recognition for their abuse. With officers in most states and with a multidisciplinary team of lawyers, social workers, financial counsellors and Aboriginal engagement advisors, we're used to navigating laws across the country. We need to turn our minds to mandatory reporting laws on a regular basis. So that's why I'm here, and I'm hoping to share some of our knowledge with you, and I hope that it's useful for you. If we could move on, thank you. So mandatory reporting across Australia, the purpose of these laws is to protect children and young people from harm by legally requiring certain people to report any known or suspected cases of certain types of abuse, child abuse, to government authorities, Each state and territory has different laws about mandatory reporting, which is not very helpful. Most jurisdictions have two different legal frameworks that require mandatory reporting. The first one is the Child Protection Framework. So these laws are usually set out in Child Protection Acts, and they identify people in certain professions who are mandatory reporters. These people are required to report concerns about child abuse that they come across in the course of their work. And this is what we think of as the traditional form of mandatory reporting. But the other framework is the criminal law framework, and it's usually set out in the Crimes Act or a Criminal Law Act in the state, and it applies to a much wider range of people. It's sometimes known as a failure to report framework because it sets out penalties for not reporting when certain individuals become aware of or believe that a child abuse or child sexual offence has occurred. So despite the different legislation in place all over the place, there are some common features, and they generally cover who should report, what should be reported, when they should report, and how to report. And that's the structure that I'll be talking through today. I'm hoping to provide you with a decision-making framework and a broad understanding of the way to work through a mandatory reporting issue. So after this webinar, there'll be some resources emailed to you. One of those is a spreadsheet that covers mandatory reporting in all states and territories. So it can be used to specifically look at your jurisdiction. It's a spreadsheet, it's an Excel spreadsheet, and the tabs at the bottom will give you the information for each state and territory. We encourage you to use it, and I hope that it's something that you'll be able to understand. It's not relevant just for GPs, it's for everyone, but it should be a useful resource. I would say, as Stacey said, that we're talking about mandatory reporting here, and we also, Thank you. We're also wanting to say that just because you are not, even if you're not required to mandatorily report, it doesn't mean that you don't have to, that you're unable to report on a voluntary level. So I'm going to focus on when you have to report, but it's always important to think about whether you might be reporting even if you're not required to. So if we could go to the next one, thank you. I'm not going to talk much here about who is required to report, because in this group, in both of those frameworks, GPs are mandatory reporters. So in that child safety framework, as doctors or a person who works professionally in healthcare, and under the criminal framework as any person, and I'll talk a little bit more about that. It's important to remember that when you are talking about the child safety framework, the information that you get that might give rise to your obligation needs to be obtained in the course of your work for it to be triggered. In the criminal framework, that failure to report, this applies to all adults in most circumstances. So will cover a lot more people who might be required to, but it's also a higher threshold because it focuses on a crime having been or likely to be committed rather than the child safety or the child protection focus on risk. It's important to remember that as workers as doctors getting information from patients, which may come under the child protection, there is also the criminal framework might apply to your patients as they might be mandatory reporters themselves. It also might come in with other workplace disclosures. So, for example, disclosures by co-workers might trigger mandatory reporting under the criminal framework. And of course, outside the work that we do, that might come up as well in social settings in our personal lives. So moving on to what needs to be reported. Unhelpfully, it varies across each state and territory, and I've sort of listed them all there. 5 broad categories: sexual abuse, neglect, physical abuse, emotional and psychological abuse, and exposure to domestic or family violence. In all states and territories, sexual abuse comes under mandatory reporting under both frameworks. So child sexual abuse, as Stacey said, is when people involve children in any type of sexual activity. A general definition that's a little bit deeper is that it's considered to be any sexual activity or behaviour that's imposed on a child or young person by another person. It can include any sexual activity, exploitation, assault, and it includes grooming and conduct of a sexual nature. It might include touching and also non-contact behaviour such as an exposure to sexual content. And it follows from there that most child sexual abuse will also encompass other forms of harm like physical and psychological harm. Next slide, please. So how do you work out whether disclosure of information given to you is enough to trigger a mandatory reporting obligation? It's not a simple question, and it will very much depend on the particular circumstances. So all of the laws talk about either your reasonable suspicion or your reasonable belief that abuse has occurred or is likely to occur. And this goes to how you assess the risk posed by what's been disclosed. So what's the difference between these two? Really, there's not much difference. Suspicion is a lower threshold, perhaps, than belief. So suspicion's a rational concern based on observed facts, and belief is a justifiable conviction based on some evidence. What I think is most useful is to focus on the test, which is whether a reasonable person with your skills and experience in the same position would have formed a belief that the child has been harmed or is at risk of being harmed. It's important to remember that with your skills and experience part, because a child psychologist, for instance, will have different skills and knowledge than, say, a lawyer. And I imagine that there's that same sort of variance, although maybe not to the same degree, within GPs as well. Now, I don't like the word evidence because it's not evidence as such. It's really just information that you've gathered in the course of your work. You don't need to gather evidence, and that's not your role. So your role in this situation is to look at the information that you've got and look at whether, when objectively assessed, it indicates that there might be a risk of harm. So some examples of this information might be that might reach that threshold is that the child tells you they've been sexually abused. The child tells you that they know someone else who's been sexually abused. And it's important to think about whether that is the way of a child talking about themselves. Someone who knows the child tells you the child has been sexually abused, or that you've observed the child's behaviour or development that leads you to believe that the child's been sexually abused. And often that's sexualised behaviour that's inappropriate for the developmental age of the child. You don't need to report rumours or unfounded suspicions. So to give an example of that, someone might come to you and say, well, I've heard that X child's stepfather was in jail for sex offences. That's unlikely to reach the threshold. But if that was combined with, say, the child's carer telling you that they've become withdrawn or that their behaviour has suddenly changed, it might actually get you over that threshold because you've got extra information there and it's more than just a rumour. Okay, next slide, please. The next thing I just want to talk about is about the age of consent, because that was identified as an area that some people find as a grey area. And this is when we're talking about sexual activity of older children or teenagers. And how does that interact with mandatory reporting? So the law is really clear that children don't have the ability to consent to sexual activity. So any involvement of children or young people in sexual activity is a crime in all jurisdictions. However, there is an age of consent that is set in each jurisdiction. Now, there's a handout that will be emailed to you with the age of consent in each jurisdiction. And the age of consent is about the age at which a young person can legally consent to sexual activity. The summary of the age of consent laws is there, and it does vary a little bit from jurisdiction, but generally it's 16 or 17 in all jurisdictions. Where the age of consent applies, this means that the sexual activity isn't a sexual offence and wouldn't require reporting unless where it would otherwise be needed to be reported. So a child who's 16, if the age of consent is 16, then that sexual activity wouldn't need to be reported as such. Now, most jurisdictions also have a close age defence, which is a defence to a charge of a child sex offence if the age difference between two young people who are engaging in sexual activity is within a number of years, and that younger person was above a prescribed age. So an example of this, for example, if in New South Wales, a young person is aged 14 to 16, so below the age of consent, but the age difference between the two young people with sexual relations is no more than 2 years, then that is not going to be an offence. So it means that in some cases, a child who is below the age of consent, it may not be an issue. It may not be harmful if that 2-year gap is there. And that is also set out in the handout. So the other thing to note is that regardless of that age of consent, it's a criminal offence for anyone in a role of authority or supervision for young people to have sexual contact with someone under 18. So this relationships of care is different in different places, but it's people who are in positions of authority and power over children, and anyone in that position the children are not able to consent, even if they've reached the age of consent, if there's sexual activity with that person in the position of care. And finally, I just want to point out that even if a young person has reached the age of consent, there still has to be actual consent. Consent is consent must be freely given and voluntary given, and therefore can't be given if there's any coercion, coercive control, threats or intimidation. And also if there's impaired decision-making capacity, so that might be the use of drugs or alcohol. It's also important to note that consent can be withdrawn at any time. Okay, next slide, thanks. So when are you required to report? So we need to keep in mind the core purpose of this mandatory reporting is to protect children from harm and to hold perpetrators account. So any instance of suspected child abuse or harm that has occurred or is occurring needs prompt reporting under all mandatory reporting requirements. So you can see there in different jurisdictions, there's different language, and most of it is as soon as practicable or as soon as possible after forming the suspicion or belief. But what does that mean? There's no definitive answer, and it depends on the circumstances and the risk of harm. But both standards envisage reporting at the first available opportunity. Maybe within hours, it may be the same day or within days, but it does depend on the information available to you. There's no guidance about what is the minimum time, but there's a little bit of guidance about what is too long. There was a case in New South Wales of a father who witnessed abuse of the child. They took 5 weeks to report it and they were prosecuted for failure to report. And another one of a psychologist who was struck off for taking many years to report a disclosure by a client. In these circumstances, there may be unavoidable delays. So an example that might come up in our practice is when we're considering making a mandatory report, we might need to speak to the client to get further information or to see if they've already reported it, or to get their permission to report it if we think that that needs to be done. So this might result in a delay of a day or a couple of days, and this could still be considered as soon as possible. It's a tricky balance. So you need to have enough information to be able to form your belief, but that has to be balanced against the need to report as soon as possible. I would say that if you're trying to get hold of a patient to get more information and you can't get hold of them, then you need to go back to the original information that you got and base it just on that. But if there is any real risk of harm that arises, then it's important to call 000 immediately. There's a question there. Why is it legal for persons over 18 in care or authority? It's not legal, it's actually illegal. So if someone is in a position of care or authority of a child, say a 19-year-old who works at a school, and they're having a sexual relationship with a 16-year-old who is technically at the age of consent, because of that special relationship, it means that is a crime because of that special relationship. Does that answer that question? I can't see the chat, so I might keep going and
there's not a chat, but yes, that thank you very much, Rachel.
Yeah, thank you. Okay, so ring 000 if there is an immediate risk of harm that you've identified. Okay, so where and how do we report? Generally speaking, under the child protection framework, you report to child protection authorities. Under the criminal framework, you report to police. And if you're required to report to both, then you'd report to both. In some jurisdictions, it makes it clear that one or the other is okay. For instance, in the ACT, the Crimes Act says you don't need to report if you believe it's already been reported to child protection authorities. So as a GP, if you have formed a belief under that lower threshold that there's a risk and you've reported to child protection, even if it does reach the higher threshold, you wouldn't be needing to report to police. There is actually an exception to the need to report if in a lot of places, if you believe that it's already been reported. And I don't have time to go through those exceptions today, but it is on the spreadsheet, so you can look at that. And that may be some guidance as to whether you are required to report to both. I mean, I would note that if your reports are made to child protection units will have direct access to police and will make their own, I guess, assessment as to whether police need to be referred, it needs to be referred to police. So how do you report? It can be done in person, but that's unlikely to be something that GPs are going to do, so online or by phone. In some states, their child protection reports will take you through a decision-making matrix. So, for example, the New South Wales mandatory reporting tree is what it's called. There's no baseline information required to make a report. Like I said, you're not needed to gather evidence. It comes down to if you believe that the abuse has happened or is likely to happen, then you make the report with the information available with you and also the reasons for your suspicion or belief. On a practical sense, I'd say put time aside to make the report. If you're doing one by phone, you may be on hold to police or child protection for some time, although you won't if you're ringing 000 with a real risk. That's why sometimes it's an online report can be more easier and less time consuming, and it's no less effective. It's okay to say that if you don't have information that you're asked for. So what are the best numbers to call? There is an Australian Institute of Family resource that gives information to service providers to report, and it gives the numbers. Is that something that I can put in the chat, or should I put it in the Q&A, or it could probably be sent by email later? We haven't included that one as a handout because it does actually change from time to time. And so accessing it directly on the website is the best way to do it. I would note that child protection might not respond to a report. There's no guarantee of what happens after you've reported. But that's not a reason to report it. It can be tempting, I guess, or you may think, well, no one's going to do anything about this, but that's not your decision. It can also be cumulative. So it may take several reports from different people or several reports of different instances for the government authority to proceed to an assessment. And so remembering that it's cumulative is important. You're not the decision maker, and that sort of is good to recognise because it takes that pressure off you. You don't have to decide whether it's happened. You just have to recognise a risk. It's your role, not your role to decide what action should be taken, but just to report the risk and leave the rest to the authorities and allow them to build a story. And that's around that cumulative stuff as well. Your job is to believe and to respond. Okay, next one. So finally, this was another issue that was flagged with me as something that comes up. So what happens if you're working across borders or you've got information about a child who lives in a different jurisdiction? Well, legally technically, a state or territory law is going to apply only in the place that you're in. Some laws might specifically talk about that extra jurisdictional stuff. So for instance, in Victoria, the Crimes Act says a person who's in Victoria or elsewhere who has information about a child in Victoria may be required to report. But if that's not spelled out that clearly, I'd say take a common sense approach. The laws are there to protect children, and the authorities in the jurisdiction where the child is are best placed to provide that protection. So the safest course of action is to comply with the laws where the child is and not where you are. In this scenario here, so you're speaking to a patient who lives in Queensland, you're in Queensland, and she discloses that her grandchildren in New South Wales are being sexually abused by their stepfather. Now, if that report was made in Queensland, there's information sharing protocols between Queensland and New South Wales, but it's going to take longer for that to happen. So I would say in this scenario, either report in both jurisdictions or just report in New South Wales. And my final point that I want to make here is to get advice, do secondary consults. There's advice lines and resources. Your medical insurance provider may provide that as well, and you may want to speak to colleagues as well. It's important to remember this is a really hard thing to do, but you're not on your own in this. And I hope that that's been helpful. I'll hand back over to Stacey.
Thank you, Rachel. We really wanted to take the opportunity tonight to really highlight the incredible work that's occurring within the primary health networks across Australia, and they have a number of different ways that they are responding to family, domestic and sexual violence in communities. So primary health networks, or PHNs, are independent organisations. They're funded by the Department of Health, Disability and Ageing to manage different health regions across Australia. So in total, there's 31 PHN regions across Australia, and there's two really key goals. So they're looking to improve the efficiency and effectiveness of health services for all people, particularly those at risk of poor health outcomes, and also improving the coordination of health services, increasing access and quality support for people. So to achieve that, they look at assessing the health needs of their region, so quite specific and contextualised information is gathered, really using a people-centred approach. They commission health services to meet their prioritised health needs of the people in that region. Working closely with providers, they build workforce capability and ensure that they deliver high quality care, and connecting health services for people to encourage better use of health resources and avoid duplication. Just move slides, please, Joby. Thank you. So you can see there, there's a lot of work that is undertaken through the domestic, family and sexual violence pilot sites. The Department of Health, Disability and Ageing have funded at least one primary health network in each state or territory to be a pilot site, and it expands on an existing pilot related to supporting primary healthcare services. So there are two different pilots. We have supporting the primary care sector to recognise and respond to domestic, family and sexual violence. That includes child sexual abuse. And it is primarily about capacity building and providing support to the primary care sector. The second one is supporting recovery and healing related to domestic, family and sexual violence, and that's around care teams and mental health support for victims and survivors. So you can see on the screen there is a lot of support that is provided to primary care across Australia within the pilot sites. They can work with local practices, they can connect in with you. So if you aren't aware of your local site, or if they are one of the pilots, please reach out to them. We will provide some information following this in an email to you with some information around the localities of those as well. Just move to the next slide, please. Thank you. So you can see there we've got just some examples of the types of support available through the pilots. So we've got primary health network targeted training and capacity building. So that's specific, contextualized to local health regions. Also responsible for health pathways updates. So that is across all of the individual health regions again. They may have a local navigator or support person, and that person is often from a specialist service or has specialist knowledge to really support general practitioners in their practice and in things such as secondary consultations, connecting in, developing, maintaining, sustaining relationships with the specialist sector, and that some of those will be on site in clinics, or you can book appointments. So really encourage you to connect in with them if you have that opportunity. As I did just mention, there are opportunities for secondary consultations for general practitioners, and I would really encourage people to take that up. As Rachel said, it is a really heavy load. There's a lot of emotion attached. There's a lot of risk. There's a lot of impacts for people, particularly for victims and survivors themselves in the workforce. And we know that there is obviously a high number of that within the workforce as well. So really encourage you to think about how you can connect in with them, connect in around secondary consultations to support your decision making, to strengthen the referral process and hopefully increase the ability to do warm referrals, and also to help victim survivors have a bit more of an understanding around what services there might be available within a national scope, but also within their local area if they would choose to access services that way. And just on the final point, there is clinical audits available as well. We just move to the next slide, please, Jovi. Thank you. So we've got a list of some of the pilot sites here. Do want to note that some of the pilot sites are at different stages across the different health regions. So it's really important that you do contact your local primary health network to understand more about what they can provide. And as I mentioned, there will be a handout provided to you following this webinar with a full list of regions, the different pilot types and the website details. As an example of some of the offerings that can occur, so for those within the ACT, their primary health network has a range of different tailored training, including specifically for child sexual abuse. So they have one at the moment that is trauma-informed primary healthcare responses to child sexual abuse under recognised respond and refer. There's a range of different pilots that have a similar training that is offered in different areas of Australia. So like we said, please contact them directly once you receive the handout. this evening, and they can provide you additional information. Their training is constantly being updated, and different things are being offered and supported for general practice as well. So if you have reached out previously, you can absolutely reach out again. And as an example, there's a range of different training that is still currently in development for the different regions. So for example, again, if we use the ACT example, they're planning some training in relation to harmful sexual behaviours for that region. So yeah, please access the handout that comes from you today. That is towards the end of our content for this evening. So I will hand back over to May and just finalise by saying that mandatory reporting is one component of responding to child sexual abuse. Really encourage you to access the resources available through the National Centre and really look at those 4 components on the screen of recognise, respond, refer and reflect. Thank you.
Thank you so much, Stacey and Rachel. That was really informative. I really appreciate all of the information that you've been able to share, as well as the resources that you've mentioned, and that will also be shared out for participants of the webinar following this, your attendance today as well. We've had some robust discussion in the question and answers, so I'm afraid I didn't get to all of them. There's still a couple still going. But I think in regards to the questions which are arising, please, this is your time to ask them, even if we haven't answered all of them, because we will try to keep hold of some of those questions for our next webinar that we'll be giving as well. We did have a poll that we were going to do. Okay, so I'm going to give you a moment just to respond to that poll. It's actually the same question that you got asked before, and we're just going to compare them. Okay, well, I'm actually really pleased to see the results of the 2 polls side by side. So just in regards to, whilst I talk to that, maybe if you just put up the word cloud as well, Jovi, and I'll speak to it as people are putting up the word cloud. But we actually had the same question: how confident do you feel to respond to child sexual abuse? Sorry, Jovi, I might get you to put the word cloud up. Child sexual abuse. When you first joined this webinar, we had probably a lot of people who really didn't feel very confident at all about the responses. I would say that following the end of this webinar, we've probably got 80% feeling somewhat confident or confident, with 2% feeling extremely confident. So I'm really pleased that hopefully we've addressed some of your concerns. And if you think back and there are some other issues which come up, then let us know. So again, this question helps us just have a little bit of a think about what sort of things do you think you would find would help you to be able to better respond to child sexual abuse. I'm sure some of you have had some questions going up in your head. How do I actually do that? This is the time to put this in the chat, because again, if there's quite a few things which come up, we're actually going to craft something out of your responses for our webinar in September. And when you put in the chat, it doesn't have to be a one-word answer. If you put in a line, the whole line will come up. But you can put in probably multiple responses if you need to. I'm going to just make a comment as you guys are answering these responses. I'm just noting in some of the questions which are coming up that some of the questions are kind of about what it might look like to actually report, or how you might get the police involved. Just as a bit of a reminder, mandatory reporting is a separate process. It's not that you're notifying the police and the alleged perpetrator gets carted away for incarceration. That's actually not how it works. Really what is happening with mandatory report, the process of it is collating information. So I think a lot of general practitioners get really despondent about the fact that they shore up their courage to make this report and nothing actually specifically happens. There is stuff happening in that information gathering is actually helping to determine processes and RIS, potentially not just for this specific family who might be involved, or, you know, as we've noticed in Victoria that sometimes there might be some greater implications which are at hand as well. So, and you may notice that there are state-specific resources. So some of them are where you make a specific mandatory report. Some of those is where you actually have processes about kind of support and advisory lines where that actually goes through. So I'm just wondering, some of the questions and answers have a bit, which haven't quite been answered yet, have a little bit of a theme, and I wonder if they might be good for our panelists to discuss, Stacey and Rachel. The themes are really about these kind of grey areas about, there's a couple of questions about what do we do if it's just alleged, that it's not the specific family member. It might be like a grandparent or friend who might be saying something. How much do I follow up on this? How do I follow up in this? So, you know, I wonder whether this might be good for us to have a discussion about rather than to be typing in the chats on this.
Thanks, May. I'm happy to jump in first, Rachel, if that's okay. I think, and Rachel mentioned this a little bit earlier, but your job isn't, or any, you know, people attending the webinar today, your job isn't to investigate. It's around what information you have already gathered. So it is around those pieces of the puzzle, and you don't know what other pieces are out there. You don't know what's recorded on the system. So your piece of information that might be something that you think might be quite small or you're unsure about could actually be that final piece that's needed to put all of the pieces together. And Rachel, I'm not sure if you wanted to add that within a legal context, but I think the more information that is available to child protection services contributes to increased safety.
Yeah, and I think that the question about the mother who believes that a friend who attended, you can ask them why they believe that, and so that's going to give a bit more context to it. But I do think that you're it's so hard to definitively say, but it would depend on what further information you got. So, you know, as a lawyer, I will always, and if we're suspecting that there might be a need to mandatorily report, we will ask people how they got that information, and that will probably give you a bit more context and a bit more confidence in reporting or not.
Yeah, no, I'd agree on that. So one of the issues in terms of what has actually been coming up is this whole question about when you report as well, how you might have that conversation with people. I'm just wondering whether that might be something I might talk to, if that's okay, because it's come up a few times. I think it's, for one thing, it's really important when we do have conversations with our patients that we also discuss our limits of confidentiality, that in most circumstances, what we say within a general practice consultation is confidential. Under the circumstance where there's a risk of life, an immediate risk of life to the person, to somebody else, or an immediate risk of safety to their child, that's when you may need to breach confidentiality. And who you're breaching that confidentiality is going to depend on what the risk is and how you're going to, and in the situation of safety to the child, that's where we're discussing mandatory reporting. So I think this is a greater question than specifically mandatory reporting in the context of child sexual abuse. It's more that context about at what point do we break our confidentiality and disclose to somebody else. We do need to have a context about our role is in general as general practitioners. As we were talking about then how you have those conversations, I think the fact that if you set the scene, if you discuss with patients before you get to that point where it becomes an issue, it also makes it easier when you're at the point where you actually do need to report. So it may be, for instance, you have a family that you know where they're coming in, they have a young child who has been potentially having school refusal or bedwetting, and you're doing an assessment, and you might discuss with the parent and the child, just to let you know, anything you do say to me is going to stay really confidential unless in those circumstances. So it means when you actually start that therapeutic relationship, they know what the boundaries of that therapeutic relationship is. And then if it gets to a point where in your assessment you actually determine that there's a risk which is arising that you think might be related to any childhood abuse, or specifically in the case of this webinar, child sexual abuse, then it could be that you have the discussion, look, you came to see me about these issues which presented. I am concerned that some of the things that you've said are leading me to believe that there might be somebody who might be involved in terms of touching you or whatever context you think that actually is occurring. And there is a requirement for us to keep you safe in that situation. These are the processes of how we might keep you safe. So it's couched in a way that the primary reason as to why you're discussing that is about keeping that person safe. I know a really big fear is about breaking the therapeutic relationship. So I think one of the things which really helps is that you're still aligned with the patient about why you're doing it. I think it's also really important to set expectations about what might happen when you actually report. The first thing is that it's not going to mean that suddenly people come up and take their child away. That does not happen. Stacey, I think you probably nod, working in the area for a long time. But I think that's what people always worry is going to happen, and that's not really the circumstance. I mean, people don't really take children away. It's really not the scenarios what occurs, but what they will do is they'll be investigating to actually assess what the risk is that's occurring. They might be collating information from collateral sources. And so it might seem like not very much happens. And that's okay. You might need to actually set the family up to let them know not much might be seeming to happen, but it is actually happening. And I think then we also need to put in perspective that they might then have further questions and interventions and discussions which are happening. I've just noticed time, so we will probably need to also close up, but I hope that's helpful. Stacey or Rachel, do you have any other comments to add to what I just said there?
I think that was a really good point and well expressed. Thank you, May.
Yeah, thank you.
Thank you, nothing from me.
Before we finish up, I just want to share the webinar for tomorrow night. We did have some questions about whether other GPs may be able to attend this webinar. I'm sure you can. I think this is obviously going to be relevant to anyone who may have any families who are affected in Victoria. They will actually be speaking very specifically to the cases and which areas are going to be involved. So I think this will be very relevant to any GPs who are going to be affected by family members there. So I really appreciate everyone who's joined us tonight. I'm going to hand over to Jovi.
Perfect. Thanks so much, May. I'd like to extend my thanks also to Rachel and to Stacey. Everyone else has joined us online. Hope you've found value in tonight's presentation. So just a reminder that a copy of tonight's presentation will be emailed along with the resources mentioned in the webinar. It should be in the next couple of days. As well as this is a CPD accredited activity, your 1 hour of EA CPD will be allocated, given you've provided us your RACGP ID number. And if you've got a couple of minutes after the webinar, if you could please complete our survey. That's all we've got time for this evening, and good night.